and giving this wonderful topic. And so hormone positive metastatic breast cancer was an area where initially we had only tamoxifen, then came AIs, then we have CDK4/6 inhibitor in first line, but as of now nothing concrete we had in the second line. So now we have 3 kids on block in the second line, and we'll see very soon how we can use them. So the burden, we know that majority of the patient, nearly 70% of the patients are hormone positive, HER2 negative, if you see all the metastatic breast cancer patient. And this is the timeline of development of all these agents. As I told, that tamoxifen from 1970s, we reached to palbociclib, I mean CDK4/6 inhibitor plus AI as in the first line. And of late we also had the option of using alpelisib plus fulvestrant in second line in those patients who had a PIK3 mutation. But now we have, if you see on the extreme right, we have 3 new drugs which are still not available in the country, but very soon they will be available, and at least we have an option to offer to the patients. This is one is capivasertib plus fulvestrant. This is for patients who have either mutation in PIK3CA, AKT1 or PTEN, and they have received at least 1 line of prior therapy in advanced breast cancer, or they have relapsed within first 12 months of completing the adjuvant therapy. Second option we have is, if you see the bottom, inavolisib plus fulvestrant plus palbociclib. Especially this is for the high risk patient who have having a progression within first 12 months of completion of the adjuvant therapy. So this can be used as a first line therapy. And we have option of using elacestrant, the oral SERM/SERD hybrid, which can be used as a second line in those patients who have ESR1 mutation after at least 1 prior line of hormone therapy. So this has already been discussed in the previous session. We have data for all the 3 CDK4/6 medicines, and they are almost the same if you see at the PFS, but the OS differs. And if you know that first line response is the best, because most of the time second line and third line response falls to less than half. So if you can clearly see in first line, the median PFS is around 24 to 28 months across the board, which falls to around 8 to 10 months in second line, and even half, around 4 to 6 months in the third line. So whenever you are using a drug, resistance is going to happen, and the disease is going to progress. Then how can we overcome the resistance and block the tumor? Also, second important point is the real world evidence shows that there is high attrition, almost close to 15 to 20% after first line therapy. 20% of the patient don't go on to a second line hormone therapy after progression. And there, based on the retrospective data, 50% of the patient discontinues their medicines even while they are on first line CDK4/6 plus AI. So this is very important, because 20% of your patient, 1 out of 5 patient is not going to be eligible for the second line. So use your best weapon first. So very important, this is the basis of using our CDK4/6 first. So this is about, now we are going to understand endocrine resistance. So as we all know, the primary, to begin with, the tumor is endocrine sensitive in more than 90% of the cases. 5 to 10% only it is initially endocrine resistant. So over a period of time, as you keep on using drugs, endocrine resistance is going to develop, and it is going to be higher as you go higher number of treatment lines. So from first line to second line, and if you go from second to third line, even it is going to be higher. So basically this is because of 2 pathways. One is endocrine ER dependent, and other is estrogen receptor independent. The estrogen receptor dependent pathway is the ESR1 mutation. So at baseline it is at around 5%, but after the exposure to AIs, it reaches up to 35 to 40%. And ER independent pathway is the PIK3 AKT mTOR pathway. So there is altogether an activation of another pathway. So if you see, we have come away from monotherapies to combination, and if you see this data of first line, AI plus CDK4/6 gives the maximum PFS advantage to the tune of 24 to 28 months. Even fulvestrant plus AI or fulvestrant plus CDK4/6 is not able to reach there. And even in second line, fulvestrant plus PIK3CA has the highest PFS around 11-12 months, provided PIK3 mutation is there. So what is primary endocrine resistance and what is secondary endocrine resistance? So primary endocrine resistance, for early stages, it has been labeled as disease which has progressed within the first 2 years of starting the adjuvant therapy, adjuvant endocrine therapy, that is primary endocrine resistance. Or in metastatic setting, if the disease is increasing within the first 6 months of using your first line endocrine therapy. What is secondary endocrine resistance? It is delayed resistance. So it develops after the first 2 years of adjuvant endocrine therapy and within 12 months of completion of the endocrine therapy. So after 2 months of starting and within 1 year of completion of endocrine therapy is secondary endocrine resistance. Also, anybody having a known ESR1 mutation is also labeled as secondary endocrine resistance, because ESR1 exclusively, majority of the times, more than 90% of the time, it will develop in patients who have been exposed to prior endocrine therapy. There is something called endocrine insensitivity. So if the disease progresses within first 2 or 3 months, in your second line treatment, it is endocrine insensitive disease. So coming to the new kids on block, the first one is ESR1 inhibitor. If you see how ESR1 works, so initially testosterone gets converted to estrogen via aromatase. So we use aromatase inhibitors to block this conversion. Estrogen normally goes to ESR1. If it is wild type, it activates it and it increases the intracellular transcellular signaling and leads to cell proliferation. What happens when ESR1 is mutated? It is a constitutive activation. So it's like a switch which is put on and never goes off. So there is continuous signaling from ESR1 to downstream pathway, and it leads to continuous cells proliferation. So as I said initially, to begin with, only 5% of the patient will have an ESR1 mutation after adjuvant AI, but after first line of AI in metastatic setting, the incidence is close to 40%. And we all know ESR1 mutation is a marker of poor prognosis, both in terms of PFS and OS, that has been shown by the Kaplan-Meier curves. So this was the trial called EMERALD's trial, where the patients who have ER positive HER2 negative metastatic breast cancer and have received CDK4/6 plus AI or CDK4/6 plus fulvestrant in first line and had a disease progression were randomized to elacestrant 400 mg OD2 versus standard of care, which can be fulvestrant AI or any of the AI. ESR1 mutation was evaluated by circulating tumor DNA. Co-primary endpoints were PFS by ESR1 mutations and PFS in all the subjects. Similarly, secondary endpoints were OS in ESR1 mutated patients and all subjects. So these are the Kaplan-Meier curves. To the extreme left is overall population. Definitely 1 year PFS was better in overall population with a hazard ratio of 0.70. It means it was benefiting both. But if you clearly see the Kaplan-Meier curve on the right, which is for the ESR1 mutated patients, the hazard ratio falls to 0.50. So there was significantly higher benefit in patients who have ESR1 mutated mutation present. So, and even 1 year PFS was 26% versus 8%. So more than 3 times number of patients were disease free at 1 year. Most common adverse event with elacestrant were nausea, vomiting, fatigue and arthralgia, most of the time being grade 1 or 2. The another ESR1 the study was EMBER-3 study, where another ESR1 blocker, that is imlunestrant, was used, which is an oral SERD, and it was used both as first line or as second line, and it was a 3-way randomization, imlunestrant alone versus standard of care versus imlunestrant plus abemaciclib, especially in those patients where it was used as a first line. So those patients who had prior adjuvant therapy and had recurred within first 12 months after completion of AI with or without CDK4/6 inhibitor were included. And for advanced breast cancer, there has to be patients who have received at least an AI plus or minus CDK4/6 inhibitor. Primary endpoint were comparisons of imlunestrant versus standard of care, for ESR1 mutated in all patients, and also imlunestrant plus abemaciclib compared to imlunestrant alone in all patients. Secondary endpoints were OS, PFS, response rate and safety. Coming to the results, if you see the first analysis, that is the imlunestrant versus standard of care in all patients, so definitely PFS was showing no difference, because you can clearly see the hazard ratio is 0.87 and the median PFS was 5.5 versus 5.6. There was no benefit in all population. Remember, elacestrant was showing benefit even in entire population, but imlunestrant was not showing any PFS benefit in all population. While if you come to ESR1 mutated patient, the Kaplan-Meier curve on the right top, so there was a clear benefit, median 3.8 months in standard of care versus 5.8 months in the imlunestrant, with a hazard ratio of 0.62 and p-value being significant. What about imlunestrant plus abemaciclib versus imlunestrant alone? Again, addition of abemaciclib was showing benefit from 5.5 months to 9.4 months, and hazard ratio was also 0.57 and p-value significant. So you can say imlunestrant led to a almost 40% reduction in the risk of progression or death in patients who are ESR1 mutated compared to standard of care. And imlunestrant plus abemaciclib had again a nearly 40% reduction in the risk of death over imlunestrant alone in all patients. So what is the prevalence of ESR1 and how it is detected? So the study has clearly shown that as you climb from first line to second line to third line, your incidence of picking ESR1 increases. So there is higher percentage of ESR1 mutation as we go from first line, which is 8% versus 27% versus 23% in the tissue biopsy. Again, what to do? Should we go for a tissue or liquid? So again, there is a data which clearly showed that the percentage of detection of ESR1 mutation is much higher in liquid biopsy sample compared to tissue. You can compare 10.4 versus 8%, 37.6 versus 27%, and 38% versus 33%. So definitely, irrespective of the line of treatment, if you compare tissue biopsy and the liquid sample, the incidence of picking ESR1 mutation was higher in the ctDNA from the liquid biopsy. So the PADA-1 study was the first trial which was designed to evaluate efficacy of periodic monitoring of the rise in ESR1 mutation by circulating tumor DNA and triggering an early change from AI plus palbociclib to fulvestrant plus palbociclib before the disease progresses clinically or radiologically. So here ctDNA was used, and it is one of the preferred methods of testing ESR1 mutation according to all the international guidelines. And based on this PADA-1 study, there was a phase 3 trial called SERENA-6, which investigated the role of first line camizestrant plus CDK4/6 inhibitor for emergent ESR1 mutated tumors during the first line endocrine based therapy ahead of disease progression, which was evident radiologically or clinically. So in those patients who were on CDK4/6 inhibitor plus an AI for at least 6 months were included in the study, and ESR1 mutation was checked by circulating tumor DNA every 3 months in those patients. And those patients who developed an ESR1 mutations were randomized 1:1 to camizestrant 75 mg OD plus continuing the CDK4/6 and using a placebo for AI versus continuing the same drugs, continuing the same AI and CDK4/6 and using a placebo for fulvestrant. The primary endpoint was PFS by investigator assessment. Secondary endpoints were PFS2, OS safety and patient related outcomes. So in this, nearly 42% of the patients were detected having ESR1 mutation. Most patients, 51% of the patients were diagnosed on first testing, and 40% of the patients were diagnosed in second to fifth time testing of ESR1, and another 10% were diagnosed after more than 5 times testing for the ESR1 mutation. So baseline characteristics were similar in both the groups. Coming to the primary endpoint, which is investigator assessed PFS. So you can clearly see the separation of Kaplan-Meier curve starting within the first 3 months, and even at 1 year and at 2 years there is a wide gap. 60% of the patients in camizestrant were disease free, progression free compared to only 33%. So nearly doubling at 1 year. And if you see at 2 years, there is the magnitude of benefit increases. Only 5% of the 5.5% of the patients were disease free in the continuation of AI plus CDK4/6 arm versus 30% being disease free in the camizestrant arm. So it clearly showed that switching over from AI plus CDK4/6 to camizestrant plus CDK4/6 inhibitor was improving the disease-free survival at 1 year and even much at 2 years in those patients who had emergent ESR1 mutation, even though they did not have a radiological or a clinical progression. So you pick up the disease very early in the trajectory of its progression and you alter your treatment regime. So this is one of the very rare occasions, if I remember, where treatment being given very early is showing benefits. So we all know biomarker testing like OV trials from ovarian cancer, where starting the treatment on biochemical relapse. So there were a lot of trials done, but all were negative. None of them rewarded. So that led to the lead time bias. But here the scenario is different. Here definitely there was a significant benefit at 1 year and even more at 2 years if you changed over to a camizestrant early. So coming to the major second endpoint was PFS2. So PFS2, even if you see at 1 year, there was an absolute difference of 11% favoring camizestrant. So this change not only increased the PFS, but also it led to a better PFS2. So ESR1, again, it's such a notorious disease, and picking it up early and blocking it with a good agent like camizestrant was rewarding in terms of PFS as well as PFS2. So what are the major side effects? There were more cytopenias in the camizestrant arm compared to the AI arm, and there was a peculiar side effect called photopsia. There is brief flashes of light in the peripheral vision, but it did not affected the daily living, and they were transient, and there were no structural changes in the vision or structural changes in eye or functional alteration in the vision. The another kid on the block we have are related to PIK3 AKT pathway. So if you see, 50% of the patient are going to have alteration in this pathway, PIK3 AKT PTEN pathway. 40% in the PIK3 will have PIK3 mutations, 5% will have A10 and another 5% AKT1. So there is a small overlap between, there can be a small overlap between PIK3 and PTEN leading to almost 2%, but very rarely there is an overlap between AKT and PIK3. So when to test for PIK3, AKT and PTEN? So most of the guidelines and international bodies have read to consensus that they are stable over time. They are not like ESR1. So ESR1 is dynamic. So initially it is only in 5% and after first line or second line it keeps on increasing, right? Sorry. So but PIK3, AKT and PTEN are not so. Very small studies have published some difference to the tune of 2 to 3% on repeat testing, which can be higher. But majority of the times it is more or less similar when you are testing in the primary tumor at time of diagnosis versus at progression. So it is wise to have look at your PIK3, AKT and PTEN at the time of diagnosis in the primary tumor sample itself. So coming to the pathway, as you can clearly see, we have two pathways, estrogen dependent and estrogen independent. And we can block both the pathways, like we are using alpelisib plus fulvestrant in second line for those patients who have PIK3 mutation. Before that, we used to have everolimus, exemestane over the board, and even now, a lot of patients don't have PIK3 mutation. 60-65% of the patient where everolimus plus exemestane is the way to go in second line. So we have two new kids on block. One is inavolisib, which is again a PIK3 inhibitor, given in addition to palbociclib and fulvestrant as a first line treatment for patients who have a rapid progression and have a PIK3 mutation. Rapid progression by means those who have progression within first 12 months of completion of a prior adjuvant endocrine therapy. And another molecule is a capivasertib. So it's a three-way inhibitor. It blocks PIK3, PTEN and AKT. So why it is important? Because AKT is a more downstream pathway compared to PIK3, as you can see. So sometimes what happens is your PIK3 is mutated, but even AKT might be mutated. So as we discussed, there can be 1% of the patient who have both the alterations, and blocking PIK3 alone will not benefit. So in this cases, even capivasertib can be a better choice because it blocks AKT. So from the SOLAR-1 and the BILIVE study, we have good data of alpelisib, and we all have been using this from last few years. It has shown a PFS of around 11 months in patients who have no prior CDK4/6 inhibitors, and a PFS of 8 months in those patients who had prior CDK4/6 inhibitors. But hyperglycemia, diarrhea and nausea are the notorious side effects of these drugs, and they are difficult to manage at times. And grade 3-4 hyperglycemias are seen in 1/3 of the patients. So coming to the new drug, that is inavolisib, there was INAVO 120 study, which was a phase 3 RCT, where patient with PIK3 mutated, hormone positive, HER2 negative, advanced breast cancer, and those who had progressed during the adjuvant endocrine therapy or within 12 months of completion of adjuvant endocrine therapy were included, and they were also had to check their plasma glucose level, and HbA1c should be less than 6% and fasting glucose less than 126. They were randomized to inavolisib plus palbo plus fulvestrant versus placebo plus palbo plus fulvestrant in 1:1 fashion, and the drugs were continued until disease progression. And if you see the PFS and OS, again both were favoring the inavolisib arm. The PFS was 7 months in placebo versus 17 months, more than double in the inavolisib arm in such a poor prognostic group. The hazard ratio was 0.42, p-value was significant. If you look at the median OS at 30 months, there was a delta of almost 10%, absolute benefit of 10% at even 30 months, and the hazard ratio was 0.67, p-value was also significant. So inavolisib was providing better progression free as well as overall survival. Coming to the third and the last drug, that is capivasertib, which is a potent selective inhibitor of AKT. So irrespective of AKT, PIK3 or PTEN, it has shown benefits. So there was this Capitello 291 study where the patient who had prior CDK4/6 inhibitor, at least one line of therapy, were included in the study, and their HbA1c has to be less than 8%. They were randomized 1:1 to capivasertib plus fulvestrant versus placebo plus fulvestrant. Remember, very important is 2/3 of this patient had baseline visceral metastasis, 2/3 had prior exposure to CDK4/6 inhibitors, and nearly 60% were having secondary endocrine resistance, and 40% have alteration in the AKT pathway. So coming to this survival benefit, the PFS, if you see overall population, again there was a benefit, 3.6 versus 7.2 months, nearly doubling of the PFS with a hazard ratio of 0.6. But if you see the AKT altered pathway, the hazard ratio was even more pronounced to the tune of 0.5%. Again, irrespective of PIK3 or AKT or PTEN, each one was benefiting while using capivasertib in addition to fulvestrant compared to placebo. Again, we all know diarrhea, nausea, vomiting are the common side effects which are related to the AKT pathway. But very surprisingly, the hyperglycemia was lower compared to the alpelisib trials which we have seen. It was significantly less while using capivasertib compared to alpelisib. So to conclude, this is the option and the schema we have in today's date. First line treatment option, most of the patient will go for AI plus CDK4/6 inhibitor. Very rarely somebody will go for monotherapy. And those who are high risk, who have a progression within first 12 months of completion of adjuvant hormone therapy, they will be going for inavolisib plus palbociclib plus fulvestrant. Again, on progression, if there is no visceral crisis, patient is stable, we can go for a second line therapy. This is guided by the alteration we have. Somebody having germline BRCA or PAL2 can go for a PARP inhibitor. Somebody with ESR1 mutation should be given elacestrant. Somebody with PIK3CA mutation, if you find, you can go for either fulvestrant plus capivasertib or fulvestrant plus alpelisib. Capivasertib, we have data for lesser hyperglycemias and diarrheas compared to alpelisib. And somebody with alteration in AKT1, then fulvestrant plus capivasertib is the way to go. Somebody without any of this alteration, either no PIK3CA, no ESR1, no germline BRCA or PALB2 and no AKT1 or PTEN alteration, then we come to our older options of everolimus exemestane or rechallenging another CDK4/6 inhibitor or using a fulvestrant monotherapy. On third line, most of the time patients are not a candidate because they are no more endocrine sensitive. And then we look at the HER2 status. If HER2 is ultra low or HER2 low, then TDXD has shown good benefit in such patients. That should be preferred over chemotherapy. And at the end, sacituzumab govitecan can be an option. For HER2 negative, there is no, they are not even low or ultra low, then chemotherapy can be the way to go. And if it is germline BRCA and PARP inhibitor have not been used, then PARP inhibitor can be considered even at this point of time. So this is the trajectory we have discussed already and will not spend for the time. So this is very important. So most of the international guidelines consensus is for testing all this mutation PIK3CA, AKT, PTEN at day 1, germline BRCA 1 and 2 and PALB2 at day 1. ESR1 mutation has to be tested on progression. Again, circulating tumor DNA is a better way to detect ESR1 mutation. PDL1, MSI or MMR, NTRK fusions are recommended by ASCO and NCCN. So these are the entire thing you need to do for a workup of hormone positive advanced breast cancer. So to summarize, first line treatment has not changed, but second line we have 3-4 different options which has evolved. Whether it's capivasertib plus fulvestrant or inavolisib plus palbociclib and fulvestrant, or it is elacestrant for ESR1 mutation, or can be a germline for germline BRCA mutant olaparib. And for this, we are going to have better options and better overall survival in hormone positive advanced breast cancers. Thank you.